Well, some of you are still grabbing lunch. I don't know about the other sites, but Francis Liu deserves about 10 minutes of introductions, but he's asked for shorter, so we're only going to give 5 minutes of introductions to Francis. I'll start, and Sion will go after me. But it's my great pleasure and honor to be able to introduce Francis Liu, who mentored my first data-driven resident paper in psychiatry in 1989. That dates both of us at the San Francisco General Hospital. It was on the Asian Focus Unit as a cross-cultural training experience in psychiatry. Francis is a pioneer in cultural psychiatry, was basically thinking about cultural psychiatry even before it had a name, and it was just a V code in DSM-5 or some distant version of DSM when Francis started working on this notion of cultural formulations. And Francis has just been a mentor to, must be dozens is probably an understatement, of sort of diverse psychiatrists, Asian psychiatrists, other diverse psychiatrists across 3 decades. So Francis it's really incredible to have him here, and it's a great honor to be able to introduce him. So, and I'll let Sion give the details. That's the
Thank you. Thank you, Dr. Zasik. I think that shows what influence Dr. Liu has on so many. So my name is Sion Kum. I'm currently a 4th-year resident here, and I invited Dr. Liu to come. So Dr. Francis Liu is the Luke and Grace Kim Professor in Cultural Psychiatry Emeritus at the University of California, Davis. As a distinguished Life Fellow of American Psychiatric Association, Dr. Liu contributed to areas of cultural psychiatry, psychiatric education, especially mentoring and career development, film and psychiatry, and as well psychiatry, religion, and spirituality. In 2008, the American Psychiatric Foundation awarded him one of its Advancing Minority Mental Health Awards, and the Association for Academic Psychiatry awarded him its Lifetime Achievement Award. He is currently Secretary of the Society for the Study of Psychiatry and Culture, and on the board of the World Association for Cultural Psychiatry, and a member of the Group for the Advancement of Cultural Psychiatry Committee. At the 2016 APA annual meeting, which we both recently attended, Dr. Liu was presented by President Renee Bender with a special presidential commendation for work in cultural psychiatry. And this just highlights some of the things that Dr. Liu has done. And on a personal note, he's very giving, warm, resourceful, and as Dr. Zasik was saying, he has an extensive list of mentees that he has. So without further ado, let's welcome Dr. Liu.
Okay, thank you very much for that very warm and kind introduction, and to see Dr. Zadzig here, someone I mentored back at UCSF in the late 80s, early 90s, and also now Sion here, a 4th-year resident here at UW. It's quite moving to see both of you, and thank you very much. I just wanted to say that my presentation and my PowerPoints will be available on the department website so that you can review all of these materials. Also, I think there is a sign-up sheet in the back for those here in the audience here at Harborview if you would like a copy of the PowerPoint. So today, I will be talking about the DSM-5 outline for cultural formulation and the new cultural formulation interview, which are tools that you can use right now in your work with patients to provide culturally competent care. I have no financial relationships with the products or organizations mentioned. My email address, you could email me at francisliumd@gmail.com if you would like a copy of the PowerPoint, and my website, francisliumd.com. My talk will start with a very brief review of what is cultural competence and why are we interested in this, and then focus on the cultural issues in DSM-5. I will give you a little roadmap of where that appears, and we will then focus on the 2 clinical tools, and I will highlight changes from the DSM-4 to the DSM-5 because there are some very significant changes that I wanted to mention. You're all familiar with the Joint Commission that accredits healthcare organizations, and in 2010 they enunciated this definition of cultural competence: the ability of healthcare providers and healthcare organizations to understand and respond effectively to the cultural and language needs brought by the patient to the healthcare encounter. Now, there's a lot in this definition that I just wanted to highlight. First of all, healthcare providers, individual clinicians, and organizations, the systems level, so it's the clinical level and the systems level of cultural competence are both important. To understand and respond effectively. So there are 2 aspects. There's the understanding and there's the responding. To the culture and language, so there's 2 aspects there, culture and language, needs brought by the patient to the healthcare encounter. So this is very real. It's like happening now in every encounter that we have. This is not culture as something out there in the ozone. So in my career work on cultural psychiatry, these are kind of my essential elements of the journey. First of all, it is a journey. It's ongoing. It's not something that this lecture is going to say, well, you can check off that box, I'm now culturally competent. This is an ongoing thing for all of us. So it starts with self-assessment about one's own cultural identity, values, prejudices, and biases. Now, this is something that we sometimes kind of skip over, but it is really essential that you start with yourself, as you'll see. Secondly is humility, what people have talked about. Melanie Tervalon and Jen Murray Garcia in 1999 wrote a seminal article on the concept of cultural humility that I believe cultural competence includes this. That we are aware of the limits of our knowledge and skills in terms of assessment. We know that we don't know. And that we need to ask, or we need to get a consultation, rather than saying, well, we know this, I read the chapter, I attended Dr. Liu's lecture, and that's it. Thirdly is valuing diversity. This is something important to us, something that we need to be aware and sensitive to cultural differences. Fourthly, vigilance towards the power dynamics that result from cultural differences. And finally, responsiveness to the cultural differences and to adapt our assessment and treatment. What are we going to do differently with the understanding that we have achieved? So why are we concerned about this? And I just wanted to mention briefly some landmark reports that I think set the rationale for cultural competence. In 2001, the Institute of Medicine issued Crossing the Quality Chasm about the poor state of the quality of our healthcare system and enunciated 6 quality outcomes as goals. And I just wanted to mention 2 of these here. One is that the concept of the patient-centered quality goal. Providing care that is respectful of and responsive to. Do you see that again? Responsive of and respectful of and responsive to individual patient preferences, needs, and values, and ensuring that these values guide all clinical decisions. I think this is very much linked with this concept of culturally and linguistically competent care. And the second quality outcome is equitable care, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And I think we would acknowledge that this is not an exclusive list. There are other cultural identity variables that I will discuss that we also need to think about. And I think this ties in with the goal of eliminating disparities in care or achieving health equity. I'm sure that you're all aware of this. And I think that our attention to culturally competent care through these clinical tools that I'll be discussing today really tie in with these quality goals. And so focusing more on the disparities, of course, in 2002, the Institute of Medicine came out with the Unequal Treatment book that for the first time documented that ethnic and racial minorities receive lower quality of health care, controlling for income and insurance status, and so on. Again, the focus of the book was on racial and ethnic minorities, and they looked at the reasons for these disparities, saying that there were system-level issues or organization levels that might lead to these disparities, but that there were also clinical encounter factors, again, between the clinician and the patient, that also contribute to these disparities, and mentioned in their words and their definitions here, biases and prejudices, stereotyping, and clinical uncertainty, that all of these can lead to disparities. And so we need to understand that these biases could either be intended and conscious and explicit, or unintended, unconscious, or implicit biases. And I know that when we talk about biases or prejudices, we might feel a little uncomfortable. We might kind of reflexively say, well, I'm not biased, I treat everybody the same, but it's something that we do need to be reflective. This is the part of self-assessment that's so critical, and that the biases, as you can see, could involve racism, biased against immigrants and refugees, sexism. I'm laughing because of the political scene of the day and how this is so evident. Classism, ageism, homophobia, biased against religion and spirituality. And again, this is not an exclusive list. And that these biases could be related to our own personal development and our personal experiences, or even as part of our training and our professional organizations. As we all know, homosexuality was a mental disorder until 1973, and the bias against religion and spirituality and psychiatry, goes back to Freud, and it has been changing only really in the past 20, 25 years. Another landmark report is the Surgeon General's report, Mental Health, Culture, Race, and Ethnicity, which came out in 2001, in which he looked and documented for the first time, again, disparities in mental health care found in racial and ethnic minorities, less access to care, availability of care, poor quality of mental health care, with the bottom line being an increased disability burden for racial and ethnic minorities. Now, this was updated in, I think, a very important book, Disparities in Psychiatric Care, edited by Pedro Ruiz and Anel Prim in 2009. This was part of Pedro's presidential initiative when he was APA president, was to further the work of the Surgeon General report to look at how other cultural identity variables can be associated with disparities in care. So as you can see here, going beyond race and ethnicity here, but women, LGBT, children and adolescents, older adults, migrants and refugees, people living in rural populations, which I think is very, relevant to UW here. The incarcerated, there's been a lot of discussion about that in this past year at the APA. The chronically mentally ill, duly diagnosed, and so on. And there are chapters on other areas as well. Do we have any questions from the audience here, or any questions from those listening here? Okay.
I know I'll just interject. I know you'll talk at us for a while, so I'll just interject a question. So, like San Francisco General, like UC Davis and County Hospital, you're at Harborview. If you were to do a random sample of folks on our inpatient wards, I think 1 in 10 might be monolingual, non-English speaking, at least on the injury wards, but there are 40 languages. So be sure to address this issue of not being able to be sort of an expert in a specific cultural group. I know you will, but it's sort of, for our trainees in here, we're constantly approaching, this boils down now to a phone interpreter, sort of where you get on a phone and you're looking for a dialect. And be sure to get into that level of the week.
Okay. Yeah, so Dr. Zadzig here in the audience brought up the 40 languages here at Harborview, and how
this is a nice broad
how would we approach this here? Yes, okay, I will get to that. Yes, good. Okay. What I'll say is that I think this comes up a lot. There are 40 languages, there are 40 cultures. How am I going to be an expert in all of these? It's totally impossible, right? The sense of being overwhelmed with all of this. Is that okay? So my response really is that I think if you hang on to these tools that I'll be talking about here in just a moment, it will at least give you a framework. It will at least give you like a little life jacket to swim through the seas of
if you're drowning, it doesn't matter if it's 1 foot or 10 feet of water above your head. So a life jacket would be useful.
Good. So we'll get to the life jackets now. Okay. So we'll just spend a moment here on the roadmap here of where we see cultural issues in the DSM-5. First of all, in the introduction to DSM-5, there is a little section on cultural issues and gender differences, which I'll just touch on in just a moment. In section 2, which is the bulk of DSM-5, where we read about the diagnostic categories and the criteria, there is, for about 80 or 90 of the diagnoses, a narrative section entitled Culture-Related Diagnostic Issues. And as you can see in the index of DSM-5, page 923, you'll see a listing of where this appears in the DSM-5, what diagnoses have a culture-related diagnostic issues section. And then also there are diagnoses with gender-related diagnostic issues in the narrative sections. And then for some of the actual diagnostic criteria, there were some changes. I'll give you an illustration of that. And then finally, mention briefly a section of DSM-5 here entitled Other Conditions That May Be a Focus of Clinical Attention, which are not mental disorders, but I think are important for us to understand, and as I'll describe in a moment. Then in section 3, which are emerging measures, there is a section entitled Cultural Formulation, where we see the outline for cultural formulation and the CFI. And then finally, in the appendix, there is a glossary of cultural concepts of distress, which replaces the glossary of culture-bound syndromes in Appendix I of DSM-4. So in the introduction, these are actual quotes from that section there, where there is a attempt to provide a definition of culture, and as you can see, it is a broad one. And these changes were initiated by a work group on cultural issues headed by Roberto Luis Fernandez at Columbia. I was part of this 25-person work group, and the idea here was to think about culture in its broadest terms. As you'll see in just a moment, makes it very explicit compared to the idea of culture in the DSM-5. So as you can see, these are some of the examples given here, that we're looking not only at ethnic groups, but also faith communities, occupational groups, veterans, and then also geographic orientation, migration, language, religion, sexual orientation, and the influence of family, friends, and other community members on the individual's illness experience. So that culture doesn't boil down to a geographic origin or race or ethnicity, that it is dynamic, not static, and that it varies from person to person, even if they share the same ethnicity or the same gender and so on. So that ultimately we are trying to move this idea of cultural competence to our ability to provide person-centered care, looking at the individualized cultural identities of each person. Here's an example, if you go to schizophrenia, of what a culture-related diagnostic issues section would look like. This first part, in fact, was in the DSM-4, that we do need to, as you can see, that cultural and socioeconomic factors must be considered, particularly when the individual clinician do not share the same cultural and socioeconomic background, when there are differences in cultural identity, that ideas that appear delusional in one culture may be commonly held in another. So the question here is, what is psychopathological, what is cultural? And this section is saying that before you jump to saying that a voice is an auditory hallucination, such as here, in some cultures, visual or auditory hallucinations with a religious content are a normal part of religious experience. Before you jump from voice is an auditory hallucination is a psychotic symptom, means a psychotic disorder of some kind, means antipsychotic medication. Before you go down that track, that you simply ask the question. You see, that's part of the cultural humility. Is it possible that there's some cultural influence here that's related to this phenomenon? An example of how the diagnostic criteria were changed is in panic disorder, the work of Devin Hinton, looking at some of these symptoms here are not part of the panic disorder symptoms, but are part of the experience that some patients that he discovered in Southeast Asia are experiencing. And then the other conditions that may be a focus of clinical attention. This section, again, are not mental disorders, but are distressing experiences that are brought to clinicians that it would be important for us to understand and include in our diagnoses. You can actually diagnose these so that we can attend to them in the treatment plan. And I think we tend to not even pay attention to these experiences or diagnose them formally because they're not billable, they're not mental disorders, and so forth. And yet, I think they tie in very much to the social determinants of mental health that has been written about more recently. So these are relational problems, abuse and neglect, educational and occupational problems, housing, and there are additional areas. And I wanted to just mention two of these problems. One is the religious or spiritual problem, where the focus might be a distressing experience involving loss or questioning of faith, problems associated with conversion to a new faith, or questioning of other spiritual values. So someone who says that I've lost my faith in God, God is punishing me for my sins, and the person is very preoccupied with this. And so what do you do with this? You say, well, this doesn't meet any diagnostic criteria, and we're just going to forget about it, and it's not important, but it may be very important to the patient. Now, the patient may also have major depression, and you may focus on that and zoom in on that, and okay, well, Zoloft for you. But if you don't pay attention to this, the patient may feel disrespected and drop out of treatment. And that would lead to a disparity in healthcare. So the idea here is that if you pay attention to this, and you may make a concomitant diagnosis of religious or spiritual problem, in addition to the major depression that you might want to treat in the usual way, that you might, if you don't feel comfortable in further assessing this, is to get a consultation. You know, call a chaplain or a religious professional to help you assess this, so that this could be also attended to in the treatment plan, and possibly make that connection of respect and response to the patient's concern in this area. And here yet is another one, acculturation difficulty, which I think is very relevant to the immigrants and refugees that you see here in Seattle. Okay, now moving on to the outline for cultural formulation. There are 5 parts. The first 4 parts are fields of information to gather, and the 5th part is the summary. How do you put it together? How does it affect your differential diagnosis and treatment plan? So what's in yellow here is the DSM-5 language, and what's in the white is the DSM-4. So cultural identity of the individual, cultural concepts of distress, which is a broader term than the cultural explanations of the individual's illness, the stressors and features of vulnerability and resilience, resilience being a new term in the DSM-5 here, but basically the stressors and supports, the cultural features of the relationship between the individual and the clinician, and the overall cultural assessment. Now, brand new in DSM-5 is the cultural formulation interview. The idea here was to help the clinician gather information to construct a cultural formulation. It's like that. The question was, okay, well, we had the cultural formulation in DSM-4. How do I actually get the information? What do I ask? Okay, so our committee felt it'd be helpful to clinicians if they were provided the questions. And so we have the 16 questions here in the patient version, the core CFI. There's also an informant version for family members and others. And then if you Google supplementary modules DSM-5, you will come to a PDF which contains 12 supplementary modules to, again, additional lists of questions for you to explore different areas in greater detail. Again, it's to help the clinician explore these areas. So these refer to different parts of the outline cultural formulation. And then here are specific patient groups like school-age children and adolescents, older adults, religion, spirituality, and moral traditions, and immigrants and refugees. Again, I think very relevant to your work here in Seattle. This is what it looks like in the DSM-5. As you can see, on the left is a guide to the interviewer, and then here on the right are instructions to the interviewer, and with the specific questions. And so I'm now going to go through the questions in order, 1 through 16, and relate that to the outline for cultural formulation. So the first question is hopefully one that you're asking already. So you get credit already. What brings you here today? And our group felt that that was the right place to start, because that's where you would normally start an interview, and here we're trying to begin to understand the patient's experience of what is distressing them. And then the second question relates to how does this relate to the norms of the cultural reference group or their social network, families and friends? How would you describe your problem to them? Now, problem here is in caps and in brackets because we would like to encourage the clinician to use the patient's own language. So it's just meant as a placeholder. And then what troubles you most about your problem? So those are the first three questions. And then the second two relate to the causes or the explanatory models. Why do you think this is happening to you? What are the causes? And what do others in your family, friends, or others in your community say are the causes of your problem? Okay, so these first 5 questions of the 16 relate to the Part B of the outline for cultural formulation, the cultural conceptualizations of distress. And these quotes are taken from that section 3 where this is further described. Basically how the individual experiences, understands, and communicates symptoms. And these could be syndromes, idioms of distress, or explanatory models. So idioms of distress are like the little tips of the iceberg. The cultural syndromes are the kind of the clustering of these, and the explanatory models are the perceived causes. Then, to understand how the patient experiences the distress and how does this relate to the norms of the reference group. And then to look at the coping and help-seeking patterns, such as professional, traditional, alternative, or complementary sources of care. Now, the questions that relate to this part of the section come a little bit later. Come back to that. Now, in the appendix, I mentioned there was the glossary of cultural concepts of distress. And this glossary provides 9 examples, and they're just examples, not meant to be exclusive, of well-studied cultural concepts of distress. And this is a little table that this is the names of the 9 that are in the glossary. And as you can see, some of these are cultural syndromes, some of these are explanatory models, and some are idioms of distress. So there are different illustrations here, and these are places in the world where this has been reported. And obviously, since we have people coming to the United States from all of these places of the world, we might possibly see these concepts of distress in the patients that we work with. Here is an example, ataque de nervios, as described in the glossary. I would recommend here Anne Fadiman's book, which hopefully you all know, The Spirit Catches You and You Fall Down, about the concept of distress of epilepsy as experienced by Cambodian or Hmong family, and how it is then viewed by neurologists, and how there was a disconnect between those understanding the explanatory models leading to very tragic outcomes. Moving on to questions 6 and 7. This refers to the stressors and supports. Are there any kinds of support that make your problem better? Are there any kinds of stresses that make your problem worse? Okay, so these 2 questions relate to Part C, the stressors and supports. And in the description of this section, there is explicit mention, and I want to really emphasize this, of religion, family, and other social networks. And that was added in the DSM-5, other social networks, and also this concept of resilience. So just as examples of this work, or this concept of cultural strengths and supports, is the work of Pamela Hayes in her book that's referenced in just a moment, Addressing Cultural Complexities in Practice, now in its 3rd edition that just came out. She lists these examples of personal strengths, culturally related personal strengths, and as you can see, they speak about a number of things that we normally would not think about as strengths. So we're always looking for strengths and how to help our patients. So the idea here is by putting on the cultural lens of this section, or asking this question in the CFI, that you might be able to elicit some of these from the patient and then utilize them in your treatment plan. And here are examples of interpersonal supports that are culturally related. And again, when we talk about family, for example, sometimes we think of just the nuclear family. And as we know, for some cultures, the extended family is very important. And religious communities are very important for some of our patients. And then here are examples of environmental conditions that might be very important for our patients, such as an altar, a space for prayer and meditation, and caring for animals. We know how important pets are for some people. And so here I would recommend Pamela Hayes' book that just came out in the 3rd edition, Alan Josephson, John Petit's book, Handbook of Spirituality and Worldviews in Clinical Practice, and also Monica McGoldrick's book, Ethnicity and Family Therapy, which has 50 chapters, not only on Vietnamese families and Japanese families, but also Russian families, Italian families, and Irish families, so that we all have, we all have a cultural identity that involves a lot here. So now moving on to the next series of questions, the role of cultural identity. And the question then is for you, what are the most important aspects of your background or identity? Okay, that's a key question. And extending that question, are there any aspects of your problem or identity that make a difference to your problem? And are there any aspects of your background or identity that are causing other concerns or difficulties for you? Okay, now this relates to the first part of the outline for cultural formulation, cultural identity. And this is what we saw in the DSM-4, explicit mention of racial, ethnic, cultural reference group, biculturality, degree of involvement with the culture of origin or traditional culture, and then the host culture or American culture. And then finally, language. That's all that was stated around cultural identity in the DSM-4. Now, a big change in DSM-5 was the addition of this sentence that makes explicit the other aspects of cultural identity. And again, this is not exclusive, that we need to be thinking of religious or spiritual affiliation, socioeconomic background, personal and family places of birth and growing up, migrant status, sexual orientation. We could add things like geographic location, such as rural areas, help to define one's culture. One's political stance or political orientation certainly is a part of cultural identity for some people, and so forth. So going back to Pamela Hayes, she has this acronym of addressing that covers many of these cultural identity variables here, as you can see. Language here is in brackets because there's no L in addressing, and that's missing, but you get the sense here of to be as comprehensive as possible here. And that something to keep in mind always is to inquire, don't assume. That's part of the cultural humility that, and just as examples here, Asian encompasses 30 Asian subgroups, 21 Pacific Islander groups. National origin doesn't define a homogeneous ethnic group. For example, there are 54 distinct ethnic groups in Vietnam, which I discovered when I visited there, the Museum of Ethnology outside of Hanoi. So inquire, don't assume. That's that's a little motto there for you. And so why is this important? Well, cultural identity is very much related to the other aspects of the outline for cultural formulation. And also it can be a source of support or distress when someone has a conflicted cultural identity. You know, am I gay or am I straight? Am I an American or am I Chinese? And this could be either intrapsychically, or this could be interpersonally, and you know, family members where we have traditional immigrant parents who speak limited English proficiency. You know, they speak Vietnamese, and the teenager is very rebellious and doesn't want to speak Vietnamese or doesn't know Vietnamese and has different values, and that could cause interpersonal stress here when we have cultural identity differences. Okay, I think we're going to now move on to self-coping, and this gets back to that part B of the outline, that these are the questions relevant there. You know, sometimes people have various ways of dealing with problems. What have you done to cope? And what have been your past helpers, doctors, and healers? And then have there been any barriers to getting care, you know, such as stigma, discrimination, language issues? And then all of that you see as a backdrop to this next two questions, which gets to the immediate situation of how can we help you now? What kinds of help do you think would be most useful to you at this time for your problem? We're directly asking the patient, you know, what do you think would be helpful? Are there any other kinds of help that your family, friends, or other people have suggested that would be helpful for you now? So we're really, you know, this is really putting into practice what we had talked about earlier of trying to understand and so that we can be responsive. So again, this touches into that last part of the outline for cultural formulation, part B, where we are asked to assess the coping and help-seeking patterns, including complementary alternative sources of care. And as we know, many patients have had no care in terms of their mental health issues, or they've come to primary care, or they've approached healers, indigenous healers, or religious healers, and mental health is often the place of last resort. And there, as you can see here, many different modalities of healing that people might engage in. And these are just some examples here of alternative approaches, mind-body interventions, and so forth. Now, the last question is around the clinician-patient relationship. Have you been concerned about the issue of differences between the clinician and the patient? Is there anything we could do to provide you with the care that you need? So this touches into part D. And again, what's in yellow here is what's new in DSM-5. Identify the differences in culture, language, and social status between the individual and clinician that may cause difficulties in communication. So it's explicitly acknowledging the importance of language and difficulties in communication. This should be obvious. Of course, if I speak only English and my patient speaks Cantonese, we're going to have some difficulties in communication, and we need to know, well, what are we going to do about that? Again, this makes it explicit here in the DSM-5. And then this sentence was added that I think is so important. Experiences of racism and discrimination in the larger society may impede establishing trust and safety in the clinical diagnostic encounter. Again, I think vitally important. And that in the summary here, that all of this might lead to, if we don't have that trust, we may not be able to elicit the symptoms, we may misunderstand the significance of the symptoms, and difficulty in establishing or maintaining the rapport needed for an effective clinical alliance. And as we know, that's kind of like the basis of our work with patients. So we really do need to pay attention here. So here are some steps to approach this. First of all, to understand the cultural identity of the clinician. This is that self-assessment, self-reflection aspect, being aware of your own cultural identity and the biases, limitations of knowledge and skills. Secondly, to compare the cultural identity of the patient with the clinician, looking at similarities and differences, and also the patient's projections or biases that might come up, and how that might affect the relationship. And thirdly, to assess how these similarities and differences might impact on the therapeutic relationship. These are issues that we deal with all the time. The idea is to apply the cultural lens in order to expand our what we should include in what might affect our relationship in terms of respect, rapport, empathy, communication, the verbal, including the limited English proficiency, the nonverbal, and the whole issue of health literacy, mental health literacy, and how this affects eliciting symptoms and history gathering. There's been some very exciting work that Margarita Allegria at Cambridge Health Alliance has been doing in this area, and also dealing with stigma and shame and transference and countertransference. And of course, we need to be aware of our own biases, but then also the patient may bring in biases, that relate to who we are, and we need to somehow be able to understand this and not take it personally. And how are we going to work with the patient around their biases and in a constructive way? So moving on to the final part here, the overall cultural assessment. Again, there are two parts, the differential diagnosis part and then the treatment plan part. Here the overall goal is by going through this, using the CFI to construct the cultural formulation, the hope is that we will arrive at a more accurate diagnosis, a more comprehensive diagnosis, in order to avoid misdiagnosis and mistreatment. So that's our goal here, and that hope, a more accurate diagnosis and a better treatment plan will lead to better quality of care. So the misdiagnosis here might be due to misunderstanding the cultural idioms of distress and the syndromes. If someone is coming in with ataque de nervios and you say, well, that's a psychotic disorder, that's a misdiagnosis, and we need, we're trying to avoid that. Not eliciting and understanding explanatory models, and again, Ann Fadiman's book, I think, gives a great example of that. Inadequate relationship to gather the history. Again, Margarita Allegria's work in this area. And what the IOM talked about back in 2002, clinician bias, stereotyping, can lead to misdiagnosis. And then other aspects that are discussed in those culture-related diagnostic issues. The prevalence may vary by culture and gender. Course and outcome may vary by culture and gender. And again, our bottom line is here we're trying to avoid misdiagnosis that can lead to mistreatment. In terms of treatment planning, there are two aspects: the process part of negotiating and managing a treatment plan to maximize adherence and compliance. We're always interested in this, and we're always worried about, are the patients taking their medications, or are they going to come back, or this is always on our mind, really. And so the idea here is, if you gather this history, and it may help you to be more successful here. And then also the content, biopsycho, and social aspects. So just to give you a sense about this in terms of the biological aspects, of course, you're all aware of pharmacodynamics and kinetics may vary, and that genetics related to race and ethnicity is a part of this, but not but it's more than that. There are environmental issues, diet and smoking, interaction with herbal medicines. So one needs to be aware of this when working with diverse patients. And then how do we think about medication strategies that might increase adherence? And what about combining medications with other biological approaches, such as acupuncture? From a psychotherapy point of view, first of all, respecting the patient and family expectations that we have elicited in the cultural formulation interview. My colleague, Evelyn Lee, who in working with traditional Chinese patients always said, be the tiger balm oil at the first interview, meaning that the patients expect some immediate relief even after the first visit, and if you don't meet that expectations, the patients won't come back. So, and then the usual questions that we ask, but again, for some patients, family is critically important, and family therapy might be a very important aspect or an approach here that we normally would not think about. And behavioral versus insight-oriented. There have been people that have written about cultural adaptations of CBT that are important to think about. And so what are the modifications in therapy? And a critical question is, what are the therapist's characteristics that would facilitate or hinder treatment in terms of who the therapist is, their cultural identity, as well as their knowledge and skills. And finally, socio-cultural approaches, again, attending to the stressors and supports in the environment, the family, religion and spirituality. These could all be supports or stresses that we need to look at, as well as the social determinants of mental health, and then working with other systems of care, primary care, and faith organizations. So I'm going to end with just some resources for further exploration in this area. I just want to mention four. First of all, 3 APPY books that just came out. The Clinical Manual of Cultural Psychiatry, 2nd edition, edited by Russell Lim, which focuses on the outline for cultural formulation. This includes video vignettes. It's twice the size of the 1st edition and did win the 2015 Creative Scholarship Award of the Society for the Study of Psychiatry and Culture. The DSM-5 Handbook on the CFI, edited by Roberto Luis Fernandez and colleagues, and includes video vignettes. A wonderful book that I highly recommend, The Social Determinants of Mental Health, edited by Michael Compton and Ruth Shim. And they have chapters here that very concisely point to these experiences which are social determinants of mental health. So, you know, in addition to the biomedical determinants of mental health that we talk about a great deal, we need, I think, to incorporate these well-documented social determinants of mental health, parallels the social determinants of health work that's been done. And as you can see, discrimination, poor education, unemployment, economic inequality, and poverty. This ties in with the other conditions that may be a focus of clinical attention: food insecurity, poor housing, and poor access to health care. And finally, the Society for the Study of Psychiatry and Culture. We will have our annual meeting next April 25th to 27th, focusing on the family. So that concludes my presentation. Thank you for your attention, and we have just a few minutes for any questions from the audience or from those outside listening. Any questions from the audience here?
We have one person in the back. Go ahead. Yes,
I was just wondering if you were going to address the foreign interpreters. Just because one of my colleagues is having difficulty with a patient who absolutely refuses to use an interpreter, whether live or on the telephone, with limited English.
Right. So the question involves the whole issue of working with the telephone interpreters and the reluctance of the patient to utilize them. Is that that you bring up. And I think that it's a very serious problem. I mean, I think that's kind of like the place of last resort are those telephone interpreters. I mean, it's very difficult, I think, for some of the patients to relate to this way of working. And I think whatever you can do here in Seattle to advocate for live interpreters, or even better, bilingual staff to what extent possible, would certainly be the better way to go. I mean, in Sacramento County, where UC Davis is located, they have really focused a great deal of attention on having live interpreters being present there. So I whatever you can do from a system, this gets into systems cultural competence. If you look at the class standards, CLAS, if you just Google CLAS, these are national standards coming out of the Office of Minority Health with a revision in 2013. There's a whole section on language access and the importance of interpreters at a mandated level. And there's been some recent civil rights interpretations from coming out of the office that further bolster, from a systems cultural competence point of view, that interpretation, live interpretation, is important. Yeah. Other questions? Yeah.
Can I just add to that, for people at Harvard who aren't aware, the Interpreter Services Department here does have mental health as a priority for live interpreters. And then beyond that, the House Calls Department can provide cultural consultation, especially with very difficult patients. And so Martine Pierre-Louis is the head of Interpreter Services, and she does a fantastic job navigating around people who are having issues with interpreters. And then Leanne Miyagawa is the head of House Calls, and she's great for cultural consultation issues.
Right. So Dr. Boynton here mentioned at Harborview there are resources for interpreters that have focused on mental health, as well as a cultural consultation service, or people that can provide cultural consultation. And I think those are excellent examples, again, from a systems cultural competence of having some cultural consultants who could help clinicians apply these tools, especially when you have problems of poor compliance or diagnostic questions or therapeutic impasses, that I think having consultants is certainly a way to go from a systems perspective to help implement these ideas. There's a beautiful book on the cultural consultation that came out of McGill, Lawrence Kiermaier being the lead editor, that came out about 1.5 years ago, that details their work at McGill, McGill's Cultural Consultation Service. Okay, time for one more question, if any? Okay, thank you very much again.